we get straight on and continue with this afternoon's programme. So we hope you'd enjoyed this morning. This afternoon, what we've got in store is our specialist nurse team, really delving further into the preparation and preparedness of the families for when they're moving closer to home and getting sort of back to the local hospitals. What kind of information and education do the team share, and how can you support that as they go on through their life with a new heart on their transplantation pathway of care? So without further ado, I'm going to hand over to Terry Hewitt, one of the transplant specialist nurses from the Freeman Hospital. Thank you, Terry.
Thanks, Kay. Hopefully you can see those screens. Give us a thumbs up, Kay.
Yes, we can.
Cool, thank you. Hi, everybody, and thank you for coming on today. We really appreciate your support. And this afternoon's a bit more about teaching the families and dealing with the actual families, and hopefully more with the shared care later as well, for you guys that actually deal with them on a local basis. So my name's Terry Hewitt. I'm the lead transplant nurse here at the Freeman. I do shudder when I say the lead transplant nurse because most people will know Julie Fett. Julie's started this role up and still works with the team, but has taken a step back, but I still call her my boss. So I do shudder when I say lead nurse, as Julie Fett is the mother of this, or as I know her, the grandmother. This is actually one of her talks, which I'm giving today, so hopefully I do it justice. So family education, this is vital. And the reason why we do family education is to make them experts of what we can talk to about transplant. They may be annoying families that come through the door at your end, but we need them to be aware of all situations and complications, which Abbas touched on pre-lunch. So what is education? It's the active process of imparting and acquiring particular knowledge or skills. And we'll look into that a bit further. Training can be practical, learning to do, or practice, usually under supervision. And as I say, what do we want to achieve when we teach our families? And it's to empower them with knowledge and skill to be able to look after their care of their child safely at home, adhere to the medical regime that is set, and to avoid non-compliance, to recognise complications early and to act on them. The child who turns into a teenager and then into an adult, to foster independence in that young person. And we need to educate them to not only work with our team, it's with all the teams that they have contact with in the community as well, from GPs, liaison nurses, community teams, the list is endless. So why is health literacy important? People with low health literacy are more likely to die younger, are more likely to have long-term conditions, miss appointments more often, find it hard to take medications correctly, feel worried and angry, and struggle to look after their own health effectively. These are major issues when we're looking at teaching our families to go home. What we educate them on is vital, and they need to be able to understand all this before they go home, so they're able to look after their child, and for the child then to be able to look after themselves. And so literacy is important in that factor. We need to share clearer health information. We need to speak and write in ways that make them understand, especially for children and also carers. And Antonia alluded to there's never a straight road. It's with roundabouts, humps and bumps. It's ways for kids to understand. We can use that for train rides. The biggest thing with transplantation, though, is you do not know what car or train you're jumping on when you start that journey. The heart comes from somebody else. It joins into that person, and that is the train ride that you just joined. So it's very difficult, but you've got to make them understand the best you can. We have to write in clear ways. The average adult UK reading age is only 9 to 11 years old. And so just us giving out information on paper is not good enough. You need to ensure that they understand what we are giving them and are able to read what you give them, or at least get a different way of passing this over. We need to use little medical jargon as possible and talk about health using everyday words, not stuff that the doctors like to use and confuse me, let alone the patient. And you need to check that they've understood that information. And just by saying, did you get that, is not a way of knowing. They can easily say yes, but that doesn't prove that they've understood what you've taught them. So who should be educated? Pretty much everybody, if I'm being honest. The child, primary carers, the mums, dads, could be foster parents, could be aunties, could be uncles, the child themselves, and that education goes over several years. If the child was transplanted as a baby, obviously you're not going to go through the education with them then, but then you have to pick certain times throughout their journey to educate them and make sure they're aware of why they're taking medicines and things of this nature. So that can change at different times when you teach them. The extended family or friends, we're very good at offering out to families meetings online to teach to families and friends, so that kids going back to school, we've gone into schools and taught friends about, that's up to the child and whether they're happy for their story to be shared. But the more people that know means we feel safer that that child can live in their community safely and happily. And not only that, the team's working in partnership with the family. That's us, that's you guys in the community, from GPs, as I said earlier, community nurses, cardiac nurses, schools, nurseries, anybody. And so we're happy to educate anybody, and we can set up sessions. So if anyone wants further education after this, please be in touch. We're very happy to share. So the knowledge and skills that we like to impart on our families is really a lifelong practice. They need to have a general understanding of the transplant issues and ongoing follow-up. It's not, you're jumping out of fire into a frying pan. It's not a cure, it's a life-limiting condition. And so they need to be aware of this from the beginning. Our follow-up is very strict. It's very regimented in what we do. And we believe, on some of the graphs that Abbas showed you earlier, our survival rates are only due to this. And it's very difficult to change things like this in transplantation. So the families need to be aware of, when they undertake this, it's an ongoing process that the family needs to buy into, and follow through on blood tests whenever they're due. Things that do upset their child that they have at home, unfortunately has to happen, and they need to buy into this. And we need to tell them why that is. Medicine management is the most important thing. And we always say to the families that we're going to treat them like idiots. Now, they could be congenital patients that have had lots of medicines throughout their lives, and parents are used to giving medicines, but the medicines that we give are completely different. The timings are completely different. The reasons why they're given is completely different. And so we treat everybody as that they've never given a medicine before. Now, obviously, they may go through the process faster if they're used to giving medicines, but on the wards, the nurses will show the parents what the medicines are, let them do them in front of them first, followed by the parents doing them in front of the nurses to make sure that they understand and are able to draw up the medicines properly, before being allowed to draw up the medicines under less supervision, before being allowed to just do the medicines themselves. So that is quite a long process, but it's vital before they get discharged that they're able to do all of that. We do a diary, which is basically a little red book, and on the left-hand side, you write down all the medications, and then there's timings of when the medicines are due. The diary is very useful because if patients write down all the medications on the left-hand side, and it's a daily diary, so they have to do that every single day. And by writing them out, they get to learn what the medicines are. Then they write out the times that they are due, and by doing that, they also understand when they are due as well. But it's also useful for the staff, because the families need to live with this. So if the families come in and say, why are you giving me the patient a medicine at midnight, when we say actually it could be changed around to be given at 10 o'clock in the evening, the family can adjust that with the nursing staff on the ward to make that happen. They've got to live with this at home. Giving a medicine at midnight is not going to work at home. By doing this, they show understanding, and we can then find out whether they do understand, because at 2 o'clock, when the medicines are due, they should be coming to the desk and saying, can I have my 2 o'clock medicines? That shows us they've understood the timings, what medicines are due. They'll be asking for the right medications, and it's a great way of ticking off that they're understanding. We will go through side effects, as was alluded on to earlier with cyclosporin, the famous hairiness medication. We will go through all of these and the effects that they'll have on different patients. A more bigger issue currently for ourselves is ordering issues. So making sure that the patients order the medicines in time, or even being able to get hold of some of the medicines. Cotrimoxazole is becoming a quite difficult medicine to get off across the country for all of our patients. And so we're having to think outside the box on how we do these sort of things. But the parents need to be aware that just giving in a prescription 2 days before it runs out doesn't mean they're going to get it. And that's not the GP's fault. They need to plan ahead, and this is what we teach them. And the adherence. We do tell the children, where possible, if you do not take these medicines, you will die. And that's a fact. You cannot hide from it. You cannot get away from it. It's a fact. And now you have to pick the age you tell the child this, but if they're transplanted as a baby, you do need to go over this at some point, because adherence is a major factor for losing organs or having issues with organs, all the complications that Abbas spoke about before lunch. But it is a fact, and it needs to be put over in that sharp way. Rejection, Abbas talked about earlier, and the signs and symptoms. Unfortunately, they are very wishy-washy. There's not an A, B, C, and they do not follow a set rule. We, as transplant nurses, are meant to see the wood for the trees. The families will ring us regularly with problems, and our first line of fault is infection, which is the one below. Most of our patients will have more infections than rejection, and most of the symptoms that they will show is infection. The problem is on day 3, day 4, when they're still reporting different symptoms and those symptoms have changed, i.e. they may now be retaining fluid, they've not passed urine since this morning, they're putting on weight, they're more breathless. These symptoms tip over from being a UTI to being, is this a cardiac condition? So the knowledge and skills we give the family is in reporting back to us the effects that the child's having at home. How they talk to us helps us make decisions. And then from that is when we get in contact with you guys and ask for an echo that needs to be carried out on that day. If we are ringing you for an echo, that's because we're worried. And an echo does need to be carried out on the day that we request. Now, that might not be easy, and we may need to work together on making that happen, whether that's a teenager getting an adult person to do adult echo tech doing their echo. There's ways and means for everything. If we need an echo, that is the only way we can detect whether there's rejection, because we're not going to get a biopsy in that time. So the families are totally aware of this. We talk to them through this before they go home, and we talk about all the signs and symptoms. Now, I alluded to, most of them are infections. So if a parent rings up and says the patient's not passing urine, it's usually a UTI. If they're saying they're breathless, they've usually got a chest infection. And that is the line that we take most of the time. Important infections from our point of view is diarrhea and vomiting. Because if they're vomiting, are they tolerating their medicines? We do say that the family should repeat the medicines if they vomited within the first 20 to 30 minutes, depending on the size of the vomit, if it's getting up to the 30-minute mark. And we would say that with diarrhea, tacrolimus especially, the level will rise. So you end up having a patient with diarrhea and vomiting who gets dehydrated quicker, then has a high tacrolimus level, which causes more dehydration, and you get yourself into this vicious circle, the diarrhea and vomiting causing the tacro to go up, all of which is causing dehydration. The family are educated on this, so they will be aware that we need to take them into hospital, do some blood tests, check their kidney function, and check a tacrolimus level. Now, we would then be in contact with you on a daily, because they will probably need daily bloods with tacrolimus levels, and we will communicate through that to reducing the tacrolimus level, getting the kidney function back online. And then what normally happens is they get over the DMV and we have to go back the other way with the tacrolimus. But the families are educated on all of this, just so that they are aware. So again, they are not annoying. They're educated, so they're aware that the treatment that they receive is done appropriately in a timely fashion. Abbas has alluded to all of these type of things previously, so I won't dwell on them. But the family, again, need to know the complications. It is a life-limiting condition with lots of side effects on it. The average, I started in this job many years ago. I started on Ward 23 back in 2001. Started in this job probably about 14, 15 years ago. And we were quoting 10 years survival at that point in 2001. And as Abbas said earlier, internationally, actually, it's 20 years that is the average now. And so these families are learning to live longer with these patients, surviving better. So these long-term complications need to be thought about. Now, hopefully, they're not happening after 9 years and more like 19 years, but they need to know about these. And we tell them about these when they're information at that time of transplant. But coronary artery disease, PTLD, might happen many, many years down the line. So we need to be aware that we need to recap our education with the family so that they don't forget these type of things. There's psychological problems, as alluded to earlier as well, when our psych team tries to help as best as possible, but that may need to be done in the community, as they can't pick up everything. Lifestyle issues. Grapefruit is the only thing that we say they can't have due to interactions with the medications. Ibuprofen is as a medication will have kidney effects. But their lifestyle issues should change in the way of initially isolation and the problems that causes. Our biggest issue with it is trying to tell to families that the reason why you have a transplant is to continue with your life. And whatever you want to do with life, you need to try and do. So lifestyle issues may be there, but we learn with the families to adapt and try and get the child who becomes an adult to be whatever they want to be in life. Now, there may be other medical and special needs, learning difficulties that interfere with empowering the patient with knowledge, but that shouldn't mean that we don't try. And there's a variety of different ways in technology and things like that to help us to achieve education to some point with every child. It may not be the full picture, but they need to know and get hold and try and make them in charge of as much as possible. So as I said, the transplant nurse specialists are the main educators when it comes to immediately post-transplant. We lead and coordinate all of the training and discharge planning. The assessment of competency is done continuously, not only by ourselves, but the staff on Ward 23 in the sense of medication giving. And if we feel that they haven't achieved it, why? And what alternative strategies can we do? Do they need things written down? Do they need pictures? Do they need sound bars? There's lots of different ways that you can do apps that can change how people learn. Communication is essential within this as well. We need to educate other professionals. We need to educate schools, because a lot of people, when they hear that the child's coming into their school, especially that have had a heart transplant, do freak out. And the biggest thing I try to make them understand is actually you need to treat them pretty much exactly like you would do anyone else. Once they come back to school, they may have physical needs, depending on their journey, but they need to be treated like anybody else, and in school getting the education that they need. So we will help communicate and support people through that. And there's a response for ongoing training after discharge. As I stated before, we need to recap and educate the patients as they become older. So this is a lifelong education. We're not the only people. There are many other educators, depending on how the patient is. Physiotherapists and OTs do a fantastic job, and we'll be educating them on the things that they should be doing immediately post-op, but also long-term post-op. Occupational therapists educating on aids that might help them to achieve. Speech and language pharmacists. There's a whole list of people, and these are just a few that I thought of off the top of our heads. There's many, many more, and including that is the people in the community as well. As already said, it's a lifelong commitment. We're not only initial post-transplant, but the ongoing challenges ahead and how their patients change within their transplant journey. Different things can happen at different times, which means they need education again about stuff like PTLD that may arise. And then again, teaching the patient about their own life, why they've had the transplant, and how they can become independent and survive within the community and become expert patients. So a quick snapshot would be early and MDT responsible for meeting practical training needs. Specialist nurses provide in-depth education to source safe care at home, so immediately getting home. Multiple educational sessions pre-discharge. We go daily, but we try to keep the teaching short, half an hour to 45 minutes, because as stated by Steph way back at the beginning of the day, how much people are taking in at this point is dubious. Once you've been going on 10, 15 minutes, half of you may be asleep right now and not taking in what's been said. It's very difficult to keep going on at patients about several things, but we will go back the next day and recap and ask questions about the day before education to see if they're understanding. And then we provide specialist resources to yourselves and community teams. On a medium term, we continue to introduce more in-depth knowledge over time. With the patients becoming older, age-specific teaching regarding sexual health, etc. encourage active engagement in their own care. And as I said, recap on the carer's knowledge, which does that. You'd be amazed on how many of them forget what you taught them and say that they didn't get taught. We know that every patient gets the same education before leaving. And then into transition, assessment of the current knowledge by the specialist nurses. We impart more depth knowledge into the individual patient and go over the training that we do at the beginning. We repeat with the patient of about 16 to 18. And we reassess and recap that as they travel through the late 15, 16, 17, 18-year-olds, aiming for their independent management of their own care. There's several barriers to learning, and this probably list isn't full. There's communication barriers, which is language. Interpreters, are they available? There's learning difficulties and disability, and as I said, there's many different ways you can do things. Sensory impairments, how can you help the patient to understand? Poorly supported families, and our social workers are excellent on trying to stop that from happening. Lack of motivation, that becomes through teenagers who think they know it all. We've all had patients that go through that teenage year, think they know it all, and they actually don't want to listen. They're hard to deal with, but you have to just keep on banging that nail in, keep on going and trying to get them to understand why you're educating them. Culture can play a factor in different ways of learning. Language is a bit part of that, but also many cultures don't accept transplanted patients into their culture. It's better these days, I must admit, but if you go back 10 to 15 years, there's several families that wanted to hide that their child had a transplant from their close family because of their culture. And Newcastle and GOS being the only two transplant centres, geographical factors can interfere with their ongoing training, so we don't see them that regularly. And so the distance between us does have an effect. When they come to see us, it's for clinic, and finding half an hour to teach within a clinic setting is quite difficult. More on long distance learning, we've started to try and introduce learning online due to the patients living so far away. Some patients who are over 3 years out will only be seen twice a year. They'll be seen 4 times a year in total, twice a year with ourselves and twice with their local hospital, which means if they only come twice a year, one of them will probably be for a CT scan to look at coronary disease. And as I say, if you put all that together with a clinic appointment, they really don't want to sit down, especially being 14, 15, 16, sit down and listen to me drivel on about the education again. So that's challenging. The issues with the online is it needs very good planning to make sure everyone's out of school, right timings of day. It needs the family to engage, to link in and actually sign on when we need them to. It is time consuming. It's quite easy for us to do teaching bang to bang to bang, back to back to back, but to fit in sections of this on different days is quite difficult and time consuming, but it can have great advantages for the patient to be able to learn at their own speed and in an environment that they know. As I mentioned earlier, assessing how they learn is vital, and we try and do it in the sense of keeping the teaching short, and then when we came back the next day, asking them specific questions regarding what we taught the day before. You have to be specific and make sure that they're answering those as you want to make sure that you're happy with that. You see the change in behaviour, as I said earlier, the patients or the parents that are coming out and asking the nurses for their medicines at the appropriate times and knowing the right medicines are due. That shows a change in behaviour by them. They're now aware of their surroundings and what's expected of them. And you actually ask them to teach you back what they've learned, and ask them to list off certain aspects of the care to see if they can understand and actually try and teach you back what they know. There's different strategies to be able to manage this, traditional methods, but there's new technology advances, internet, texting, apps, Skype, many different ways to manage. We do tap into local services and support groups, especially with things like health and generalized eating and healthy lifestyle type things like that. Local community groups we will tap into. New initiatives is a bit more about the education in teenagers, which I'll go into shortly. But we do try to make them all person specific. You can't have one blanket teaching system correct in your head that's going to be able to educate everybody. You need to be adaptable, and learn with the patient how the best way to get the knowledge through to them. The new initiative I'm on about is Young Persons Clinic, which is aimed at 16 to 18-year-olds. We have a new adult transplant consultant in the adult service and a new sister. The consultant's been there about 1.5 years now, and the sister probably 3 years. And what is amazing is that they're really keen on the transition process. So whereas previously we had a transition process in place, it felt like the paediatrics were pushing more than the adults receiving, whereas I do think that we are being definitely met in the middle now. We now have a much more structured education package for these young people, and we're changing the clinic regime to incorporate the education to ensure that the adult team gets a chance to meet them more and educate them about the adult follow-on care as well. On how to assess the learning, we actually try and start, depending on when the patient is transplanted, depends on when you start the transition. If a patient is transplanted at 15, you obviously start the transition pretty early. If they were transplanted as baby, you would want to try and start the transition at about 14. And there's a ready, steady go which we've adapted from that. It's quite useful in the sense that it's like a questionnaire that's asked to 14-year-olds about what knowledge they know, which identifies the gaps, which you then try and educate, and they refill that in around 16 to see what they've learned and then what more they need to learn. And then you fill it again at around 17 to check that everything's ticked off or whether you need to go over anything. It's ready, steady, go is what we use. It's not actually there. We've adapted it from that, which is very useful for our transition process, which Kat and Antonio have put a lot of work in over the last 1.5 years to achieve with the adult team. All in all, we're trying to do that so they're making the young person able to look after themselves and be aware of what is coming towards them. Because if they're transplanted as a 2-year-old, we've known them all their life. They're used to us. They're used to Clinic-y, the staff in Clinic-y. And so at 16, they're actually seen in the adult setting by the paediatric team. But so they get used to that. It is a big change for not only them, but the family as well. So you need to transition them as well at the same time and try and make them just taxi drivers rather than answering all the questions. The adult team, Steph alluded to earlier, has an education website, but the paediatric team here are undergoing a paediatric website as well. So hopefully we'll send that round when they're up and running to hopefully help out as well. The biggest thing from our point is they're never too young to learn. Trying to get the kids aware of their life. Transplant is a life-limiting illness that they need to know that and buy into. And so educating the child is vital. And depending on when you want to do it, Gabrisha here was very keen. I wouldn't be 100% sure she got everything right, but hey, you got to love a trier. And a previous consultant that used to work here, who now works in Birmingham, used to say this to me all the time, and I totally believe in it. A wise man never knows all, only fools know everything. There is never a stupid question. We're always happy to help, and we're always happy to give advice. So please, please, please get in contact if you need anything. Thank you.
Thank you, Terry. I can't see. Oh, we have got some questions. It's around transition. I'm not sure whether you've seen this one earlier. From Susanna, who said, do you always involve clinical psychologists to support young people during transition?
It's difficult. I'd love to say yes, but they are limited service and resource. So yes, in the patients that are already known to the psychologist here at the Freeman, they would have a long-term relationship. There's quite a few that kind of have issues around that 12, 13, 14-year-old where they start to understand more about their journey and what's kind of happened to them. So our psychology team, will always meet them, but they will often then try and use the local psychology teams or CAMs and things like that, more local to the child, mostly because of resource. I'd love to say different, but it's quite difficult. The families may live in Wales, Southampton, and it's very difficult to get good psychological support this end. If they only come twice a year, they're only going to meet them. I know there's Zoom and things like that, but that limits that type of discussion. So The short answer is yes. The long answer is where possible.
Thank you, that's great. Any further questions, keep popping them in. We'll keep the afternoon moving in the interest of time. Oh, hold on. You might want to respond to Julie Walsh's comment in the box, Terry. I know what I'd say would have outreach nurses everywhere, improved patient pathways. Jessica's just asking, as well as Susanna, what age do you start transition? I know you had said that, but if you can just reiterate that, Terry.
As I say, it is difficult. It depends on when they have their transplant. In theory, every clinic they come to as they turn sort of 12, 13, we're wanting them to know their medicines. We're asking them questions within the clinic. So you could say that we're starting it then. We're not doing it under any banner. We're not calling it transition. We're just literally asking the patient more and more questions and hoping they're more aware of their medications and things. It's a very simple way of starting, but also highlights the importance of the medicines, that they should know it. So really at the age of probably 12-ish that we're trying to get them to be more involved in their own care. But as I say, we've recently adapted those questionnaires, which would be for about 13 to 14-year-old is when they're going to first fill them in, and then 15, 16, followed by 17, 18. But as everybody knows, transition is different for everybody. At 16, we had a young man recently. I say recently, it's probably a year ago now. But at 16, he'd left school, he had a job, and our clinic's on a Monday and Tuesday and didn't suit his job. So he was very well up with all his education. He knew about life. He knew about things of that nature and wanted to transition. So we transitioned him into adult care at 16 and a half, with the adult team knowing him. He'd been transplanted many years. And he carries on, but that's his lifestyle. And so that's why we do. So it varies from patient to patient.
Thank you very much for that. So we will continue on. I do believe, Terry, you're going to keep going.
Yeah.
We have the pleasure of continuing dulcet tones. So Terry's now going to explore, I guess, the relocation of patients back to their place in the world, their place in the country, and how we can work together to support the patients in a shared care model. Thanks, Terry.
Is that good to go?
Yeah, perfect.
Cool, thank you. Right, so yes, we're on to shared care, and this is the bit where we thank you guys really for the people. I know there's people online that we deal with all the time, but this is just to highlight areas that we need your support in helping these patients to develop. Hopefully you've realised throughout the day that not only the patients live the transplant, but the nurses and the doctors do as well. And we will do anything we can to help them survive as long as possible. So we need your help with that. And so the last part from our point of view is the shared care that you guys help us out with. So as already been stated, we cover everywhere, pretty much. But transplant shared care starts pre-transplant. So when you send your assessments, that's where shared care start, because the information you give us at that point helps us with the decision making of whether they're transplantable or not. The pre-transplant, the peri-transplant decisions that are made with anaesthetists and things like that, if the patient's had several operations. So actually the shared care part starts a lot longer before you get someone like me on the end of the phone asking for help. But obviously the post-transplant is the biggest bit from our side. Currently, we have 126 patients in our MITs. There was about 142 about 2 years ago, but Antonia and Kat's transition into adults has knocked that figure down quite a lot. There's 71 of those 126 patients are in shared care regime, and that's over 13 centres around the countries seen on screen. It is there is patient criteria to it, so it's not a given that every patient will have shared care, and it's also not a given that they will keep that shared care. So things like lack of attendance, or if they've had more rejection episodes, or if we're worried, we won't offer shared care. That's not because you guys aren't good enough to look after them. It's just that we need to keep a closer eye on them, and we're quite possessive like that, and we want to keep a close eye on them. So do not be offended if they miss a shared care because we want them to come to ourselves. It's mostly because we're worried. And they have to follow the shared care protocol to do this. So on the screen on the left-hand side, as I look at it, that's by country. So in England, there's 55 patients not on shared care that come to ourselves. There's 44 in England that are, 11 in Scotland, 1 in Wales, 8 in Northern Ireland, and 7 in Southern Ireland. And on the right-hand side is the centres that we use, and we're very thankful for. And obviously, these numbers will change depending on where the transplanted patient is, but that was taken, I think, a month ago I did that, so it can't be that far wrong with where the patients are from. And as I say, we thank everybody for that. So transplantation, it's not taken lightly, as I said before. It's not a given. And as long as there are boundaries within there, it works out for all concerned. It has to be formalised and robust. So the centre that we're sharing with have to be aware of our protocols and things. It requires joint participation of both the local teams, GPs as well as cardiology teams, and primary care, and also the specialist nurses that we're indebted to, and making sure that the care is given. And it promotes and supports the continuity of the care of the patient. So the shared care principles is the first and foremost, it needs to be safe. It has to be safe for the family. It has to be safe for the team in the local area that are looking after this patient. And that is our foremost issue. The local team may be able to get the tests that are required to carry out, but does that centre know what to do with those tests, where to send them, and in a timely fashion? We're obviously happy to share all of our protocols, and especially at time of rejection, we can share what to do and when, as an example. We're happy to go through anything on the end of a phone to help you look after these patients. But everything needs to be agreed, and the standard of care needs to be met, that everybody does the same thing. So echo reports, if you're unsure with an echo, please contact us, and that should be in this shared agreement. The roles and responsibilities is not just a given. We don't expect you, if you're not happy with what we're asking, please come to us and tell us why, and we can support you on that. You need to be happy in what roles you're taking, responsibilities you're taking under, because when they come to you, if there's any signs and symptoms of things like medicines non-adherence, echoes being off, anything really, slightly erratic behaviour, drugs, drinking, anything that can change the patient's care, we would love you to be in contact with us. This makes the patient's care centred to them. It means it's very individualised for them, and it means that we can continue to look after them safely. It needs to be coordinated, and that's why we spend most of our time on the phone asking you guys for help and ask for calling in favours. But we will coordinate any care that's required. Any results that were needed, we will be in contact for. But anything you can do on the other side of that in sending us, we totally appreciate. As you can imagine, if we have 70 patients seen in shared care in different centres around the country, it's very difficult for us to get all the blood results, all the results from CTs, all the results from anything that's happened to the patients. So we need you guys to help us out by sending results as well. And that's timely effective in the communication of emails, phone calls, anywhere else you need, letters, anything else that you need to be in contact with us. And it is a partnership. You are part of our team. When we say the transplant team, I would include anyone that does shared care for us, because you see them as much as we do, which I'll show you shortly. And the families are used to you guys. They know you very well. So when we say the transplant team, you definitely are part of our care. It obviously benefits the family. It's convenient to them. It's 500 miles for some of these patients round trip to come for an echo, ECG, couple of bloods, and to see me mess about in clinic. So it's a long old journey. So it's convenient for the families, and it helps them out no end. It helps with the continuity of care. It means that these families can get to the appointments more easily. There's an open rapid ward access, open rapid clinic access. If it's an emergency, there's immediate and effective care that's for them able to access. As I said before, a familiarity with the units that they come from. Often knew them pre-transplant and might have gone through surgical operations pre-transplant, so they know them very well. But it's the whole spectrum within the community. There's GPs, local cardiology teams, nursing and medical, liaison nurses. But we also include that in the community nurses that go out to flush our Hickman lines, change dressings, assess patients on pathways, on palliative care pathways. There's lots of different areas that we will share care with people in the community. And within that, education and training, as I stated in the previous talk, to help the shared care people understand of why these families are annoying and coming in asking for certain things. And we can also use more efficient and use of specialist resources. So a patient sitting here in a bed that's got a tracheostomy and can't get home because of it, should be going to their local hospital and seeking the advice of the local specialist team that will be looking after them locally. That's just one example, but the specialist resources known to each individual hospital that we would share care with, they've all got a multitude of sins, gastro issues, feeding issues, all sorts really, renal issues, which will need specialist support from the local hospitals. On the screen now is their actual follow-up regime, which is very intense for anyone that has to keep going to hospital. So in the first 3 months, and that they will be seen weekly. So that's from time of transplant, that's not from going home. So in theory, if they're in hospital for 6 weeks, you'll see them weekly for another 6 weeks. That is all at the Freeman Hospital. That won't change, we would just keep seeing them at the Freeman Hospital. The next 3 to 6 months is fortnightly, and that's when we offer shared care. And if it's got shared care from that moment, that would be 3 appointments at the Freeman, 3 appointments at the local team. And as you see, as you go down, 6 to 12 months is monthly, 3 on each again. The next year is 6 weekly, and then 4 or 5, depending on which way it falls in the year, alternating between the hospitals. 2 to 3 years is 8 weekly, again, 3 each over the year. And then after 3 years, the patient gets a choice, which is they can go 12 weekly, which is just 4 appointments, 2 with ourselves and 2 at the local hospital, but they have to have bloods in between, so that's 4 blood tests, making it, because we do bloods every clinic, that's 8 blood tests. If it's a younger patient that's difficult to bleed, they will often stay on the 8 weekly regime, which means only 6 bloods throughout the year, and that's very shade. But that's to show you that you see them as much as we do. Obviously, if there's a problem, we would see them more frequently, and so this is to highlight that you are completely part of their care and following it through. So your responsibilities really, and I feel cheeky saying this, is to be available for the patient, the regular outpatient assessment, or the urgent and the emergency appointments that they may or may not need. Routine investigations, including blood tests, monitoring immunosuppression drug levels. We would be very happy, for the more experienced cardiologists that see our patients, and there's lots of cardiologists out there, adjusting general medications as required, hypertensive medicines, but also things like being aware of drug interactions and the medication side effects in case any new medicines are started, interfering with our immunosuppression, and being aware of these post-transplant complications that Abbas highlighted pre-lunch. Because these need to be identified and communicated with ourselves early, and communication is vital to make any of this work. So a huge responsibility is getting in contact with ourselves. So when the patients come to yourselves for any review, this is basically all that we would do here, you'd be asking regarding non-specific any symptoms. Is there any cardiac symptoms? Looking for drug compliance. Any psychological issues, have they been noted? Lifestyles, including exercise, tolerance, health issues, and then examinations, usual observations, ECGs, looking out for murmurs, etc., looking out for lymphoid issues, so enlarged tonsils, etc., enlarged livers, skin lesions, anything untoward in that nature would be on our examination that we would do here, and would expect you guys to follow through on a clinic appointment locally as well. Covered previously, these are our routine investigations. So it'll be their immunosuppression level taken. Needs to be in the morning, taken pre their dose, and it goes in an EDTHE, the full blood count tube. For patients that are on sirolimus plus and minus cyclotacro, They can get both results off one sample, but 2 samples is preferred, but they can get both results off one. And then as you see, the blood's taken on. So we'd always do a full blood count using these LFTs bone profile every single time we do bloods. Now, obviously, some patients are very difficult to do bloods on, and there needs to be discussion between the centres about which are the ones that are more important. But as you can see by the descriptions on the right-hand side of the screen, there's a reason why we do every single blood, and it's mostly due to medicines interfering with those blood results. And if things like white cell counts have dropped, we would have to stop azathioprine or MMF. If things like the creatinine has changed and risen, is there a reason for that? Is the tacrolimus level high? Is there other reasons for that? So this is why we would want both, why we ask for all these bloods every single time and not just a tacrolimus level. We would use every single blood to help us make a decision about levels taken on cyclo and tacro. As Abbas mentioned earlier about tacrolimus and diabetes, we would carry out glucose, and then we'd be looking at, again, sirolimus interfering with lipids, etc. And then it's ECGs and echoes, looking at cardiac function, looking at rhythm issues, and not only looking at it, but is it different from previous? ECGs and echoes are different from a normal heart patient coming into your normal clinic. They're often different beforehand, so you need to get used to what is the norm for your patients. But any changes need to be reported. As Abbas said earlier, these may or may not be signs of rejection, so we would need to be contacted with any changes in their regular. And we can upload, send to you any ECGs and echoes that we've done here to help make those decisions, but more importantly, sending them here so we can compare with what we've got as well. Another one of my analogies really is just a description of what Antonia said earlier. As you can see by the lamppost on the right, there are so many different issues with our patients that may or may not come through your door into your clinic happening. The road on the left is windy, it's all over the shop. It's never straight, it's never easy. But as you may or may not see, along this journey, there's different people in those hills. And that's you guys helping us to get those patients on that straight and narrow, dealing with any of those issues you see in front of you and trying to get them back to that beyond the hills above and onto a happy life. So Abbas kind of covered this earlier really with the presentation of scenario. But in essence, when they phone us, we always think infection first. So fever, high white cell counts, most likely infection, full infection screen, antibiotics. Abbas highlighted in that there's some weird and random infections that they may or may not have. And we're only too happy to discuss this over the phone and send off specific tests that are required at the time. Looking out for that PTRD with large tonsils, any lymph nodes anywhere else that are enlarged, and the tests, chest x-ray, full blood count, EBV, PCR, LDH. We would all advise you these over the phone and take you through the pathway. Again, this isn't common stuff, so we wouldn't expect you to know off the top of your hat what to do. We would be happy to advise on any of this. And the final 2 columns, both are different presentations, but both can be rejection. And so you've got to look at this and think things through properly. And so just a detailed handover about what you found and why, and any echoes, ECG, would be really helpful in us making the decision. If there is worrisome of rejection, we would always treat where they are. So if they were with your cells, we would advise you on the steroid dosages, which is 10 milligrams per kilogram, once a day for 3 days. And we would always give the first dose there. We have had in the past, many years ago, a patient who the handover wasn't brilliant. It turns out to be rejection, and they arrested on the way here. We would always treat initially there. As soon as you can get steroids into them, the better it is for their outcome, and treating the rejection and getting the function back to normality. As I said earlier, we are here to help you and support you the whole way through. We can guide, advise. There isn't a silly question. That's our numbers on the screen. We work 9 till 5. I'm never home at 5, but we do work 9 till 5. And at the weekends, there's Ward 23, and there's doctors always available on that. So you're never alone. Any worries, any queries, please contact us. We would only be too happy to help. So in conclusion, shared care, it needs to be meticulous follow-up of paediatric cardiac transplant patients. And it's important in the long-term, medium and long-term care. The early care, they're being seen regularly between ourselves, so you will pick up on things. It's more when they get further out, and as I say, seen 4 times a year. The long-term effects, other side effects, patients changing, growing up, starting to do different things that their mates are doing. They're the sort of things that you guys can pick up and communicate with ourselves, which makes the patient's survival rates a lot better. It needs to be well planned and organised, with share care agreements provided, which we can do. You guys attending things like this will make you more aware of the potential problems and the follow-up people may develop. And there needs to be robust communication links between the partner shared, you and us. We need to be able to communicate with each other and make sure that all questions are answered and nothing is missed. So thank you again for listening. Can you go and get Sophie? She's in cardiac entrance. Cardiac, yeah.
Thank you, Terry.
Thank you.
2 excellent presentations. Really enjoyed them. Thank you. I don't have any questions popping in at the moment. I'll wait and see if anybody joins that conversation.
Well, I know there's some liaison nurses out there that I deal with every day, so they should be annoyed and have their chance to answer me questions.
Has my camera gone off again, honestly?
Gillian's status.
No. So we have a hand up from Gillian Stokes. Gillian, you'll have to bear with me 1 second. This is a different setup and I have to find you first, which is a bit silly because you would think it would be in. There you are. Gillian, if you go off mute now, you can ask your question.
Oh, she's just coming.
Oh, your question's in the chat.
No.
Yeah.
I've got to move because it's over.
Okay. Terry, can you hear me?
Yeah, I can hear you.
Yeah. Currently, we don't include glucose in the shared care review bloods. Would you recommend we start doing that or leave that for you guys?
Best practice would be to do it. It's not a thing that normally happens immediately. It's obviously one of these things with all type of diabetes. We don't see it that often. In my time here, we've probably seen 3 patients with it. One of them switched back off tacro to cyclosporin and the diabetes went away, so it proved it was the tacro doing it. The other 2 had diabetes in the family, so it could have been just due to that anyway, and so they just carried on. We would repeat them. It depends. It's difficult. Yes is the short answer. I would always include all of our bloods in them. But as long as it's being kind of done twice a year, which is what we would do in the longer out ones, then it is a way of monitoring it. If there was a patient we were worried about, Gillian, I'd hope I'd contact you and say, could you do a glucose every time they come to you? But normally they just plod along fine, and it's not very common that that's an issue.
Gran, thank you. Terry, can you still hear me?
I can hear you, yes, Kay.
Unfortunately, my computer is about to do a reboot again.
Right, so Kay seems to have gone. I may continue. So if there's no other questions, my friend, is Kay coming back? Oh, there is a question. There's a hand up. I don't know if I can do hands up.
I'm just looking, Terry. There's D'Souza Susanna. She had a question in the chat here. If you're happy to take a couple more.
Yeah, go for it.
Yeah. So in terms of preparation for discharge and shared care, do you invite local teams for a pre-discharge meeting?
We try to. We're not brilliant at it, I must admit. We try to. It depends on the often the families pre-transplant and their ongoing care, because there's often a lot of paediatricians and things like that are involved in the patients a long time pre-transplant, and we definitely want those involved in the discharge meeting. We do try to get them involved. Sometimes knowing who they are for that each patient may take a little while to get used to, so they're not always involved in the discharge planning meeting. And it also depends on the patient's kind of problems. So if they've come through cardiomyopathy doing very well, straight through and out the other side, they can be with us 3 weeks. And so often there's not a case for them to join into our discharge planning meeting, but it is in one of our plans, or that's what we should do. It's in our criteria, is we should be inviting the local teams. Often it is the community nurses and things like that, more than doctors, I must admit, and things. So the more hands-on, I have to say.
Well, thank you. Kay, you all right there?
I am coming back. I'm just on my phone at the moment while the computer reloads itself. Terry, do you have Sophie in?
Sophie is here, yes.
Yeah. Are you happy to get started with Sophie? Is Sophie heavy?
Sophie's nodding at me, scared. Please be nice to her. She's the loveliest mum you've ever met in your life.
We will always.
Yeah.
Yeah.
Hang on, she's coming. I'm just sharing the screen. So can you see that, Kate?
Yeah, I see it perfect.
Just the down arrow. Easiest thing is the down arrow. Yeah.
Hi.
Hi.
Are you all right?
Yeah, you.
I haven't got a camera. I'm so sorry. It's been a bit of a pain. I'll try and get it on so I can at least see you. Sorry about that. Okay, there you are. Hi. Let me introduce Sophie. Sophie is a mummy, an amazing mummy, and Sophie's going to walk you through the lived experience of transplantation up here in the north in the Freeman Hospital experience. So Sophie, I'm just going to hand the floor over to you. If you need any one of us, just let us know. We're here with the tech stuff.
Okay, thank you.
Thank you.
At my 20-week scan, the sonographer told me she could only see 2 of the 4 chambers of my baby's heart. I was told I would have to go home and return in 4 days' time to have a more detailed scan with the fetal medicine team. I felt numb and confused. Something clicked in me and I told her I could not wait the 4 days. I begged her to check if they could see me then. Thankfully they did, and Frankie was diagnosed with hypoplastic left heart syndrome. I was given 3 options: a termination, compassionate care and medical intervention. The first 2 options were a definite no from me, and I immediately decided that I would fight alongside Frankie for as long as he could. To be told that the survival rate of the surgical route was only 70 to 80% at 1 year left me feeling terrified and heartbroken. They explained that this meant 1 in every 5 babies that had this condition and chose the medical intervention route would not see their first birthday. I remember feeling that this was a very harsh conversation, but it was also unexpected and new. I suppose anything could have been said to me that day and it would have been painful. Fast forward to my 24 and 28-week scans, and I was told Frankie's form of HLHS was the most severe form with an intact atrial septum.
Move on.
No.
Yeah, sorry.
I could not believe it may be worse than the original diagnosis, with survival rates to 1 year reported as between 50 and 60%, nearly half not making it to 1 year of age. I was asked 3 more times after the 24-week scan to decide whether I would like to terminate my pregnancy or reconsider compassionate care. This was becoming hard as I had to keep going over the same thing. I was starting to get a little tired of explaining my decision. I completely understand why they have to ask so many times. However, it was absolutely terrifying to feel constantly reminded that my baby was sick enough to be allowed an abortion at this point, or to allow my baby to die in front of me without any medical intervention. It was extremely tough to keep going over it, but I believe it was imperative in making me understand how serious the journey was going to be. I remember thinking that there was just as much chance of Frankie dying as there was of him surviving. I was constantly being told by family members I was being negative and had to keep thinking positively, and although I knew they were just being hopeful, I also knew that I had to be realistic. This was my baby and I knew the odds were not good. The team decided to perform an exit procedure and operate on Frankie as soon as he was born, by opening his chest and placing a stent directly through the wall of the heart. I signed a consent form for this before he was even born. The staff quickly realised that I was a very need-to-know-everything kind of person, and they gave me as much information as they possibly could, which really helped me feel like I had a little control over what was going to be a crazy new way of life. So filled with as much knowledge as possible, our journey began when Frankie was born on the 8th of August 2014, directly into cardiac theatre. Frankie was now recovering from the intact atrial septum corrective surgery, and we were on the paediatric intensive care unit preparing for his Norwood procedure. This time I was quoted a 70 to 80% chance of survival. I knew this meant that 1 in every 10 babies, 2 to 3 receiving this surgery would die. I was informed of all the risks, and I believe again having such honest opinions from the team around me really helped reassure me that my realistic approach was right for me. I knew the surgery was a very complicated one, and this was not the time for false hope. Of course, deep down, I was hoping and praying that Frankie would get through this, but I was definitely made aware that he might not, and this is what kept me focused.
You're on that one.
Sorry.
You're doing fine, you're doing fine.
Frankie actually made a remarkable recovery, and although we had a few setbacks along the way, Frankie was able to go home for the first time at 4 months old. When Frankie was 8 months old, it was time for his Glenn procedure. This time survival rate had increased to 90%, and after the previous 2 surgeries, this felt a lot less risky. I knew this is still a high percentage of mortality, with up to 10 in every 100 patients not surviving, but Frankie's chances had never been as good as this. I was made to feel hopeful at this time by the team's positive attitude regarding the surgery itself and recovery. Obviously, I knew the risks were still there and were higher than the average person would be happy to sign consent for, but we all knew we had to be where we had been previously with Frankie, and this slightly was less terrifying. The surgery was a success, and Frankie was home within 2 weeks. When Frankie was around 17 months old, I knew something was not right. I brought forward Frankie's cardiac appointment, at which my boy was diagnosed with heart failure. His heart function had previously been normal and was now unexpectedly severely impaired. This conversation was very to the point, which the team knew I would appreciate. This is how we had dealt with everything so far, and I was grateful that even though things had taken a turn for the worse, we were still working together with the same approach. At this point, I felt my own heart was breaking. I was told that the only way Frankie could live was if he had a heart transplant. Nothing can prepare you for that information. I will never ever forget the feelings I felt that day. This was so much harder than everything I'd been through previously with him, and I had no idea how I was going to get through this to be strong enough for him. I was told that more than 80% of transplant patients would survive the operation and recover well, which was scary, but it was a better chance than some of his previous surgeries. I was also made aware that hearts were not always available, and there was a good chance that he might not receive a transplant in time. This was terrifying to hear, especially as his cardiologist seemed extremely worried about the chances of Frankie dying on the waiting list. The efficiency of all tests being done to assess him for transplant and the information given to me, whether good or bad, hugely impacted on how I was able to accept it and moved on with a focused state of mind to when he was placed on the transplant list a few days later. Now I was finding a balance of being realistic, but also staying positive and hoping that a call would come on time. Frequent clinic appointment and open access to the ward really played a big part in having normal everyday conversations with staff about their families and what they'd been up to kept some normality at such a terrifying time. Throughout the whole transplant journey, I was fully aware of the possible outcomes, but I was trying to keep things as normal as possible for Frankie, and the atmosphere and our visits definitely enabled me to do this. After a long, hard and daunting 21 months, Frankie received his gift of life and heart-wise recovered very well. Although Frankie's heart was working perfectly, his kidneys now were not. Frankie was now in end-stage chronic failure, which required him to have hemodialysis 3 times per week. After 6 months of dialysis, we were sat down by the team and told that Frankie would need to go on the transplant list again and wait for a kidney to become available, which once again had torn our world apart. I could not believe that this was happening again. I felt like Frankie had been through enough and now should be his time to enjoy life, but I quickly remembered how poorly he had been before his heart transplant and realised that I had to be grateful that he was here and well enough to be eligible for yet another transplant. After needing dialysis for nearly 2.5 years and being on the transplant list for 8 months, Frankie finally received his dad's kidney on the 30th of January 2020. This time, the whole experience felt terrifying. Although medically this was probably Frankie's least risky surgery, to me it was definitely the most scary. We were not at the hospital where he had received all of his heart surgeries, so we were not with our usual surgical team, PICU nurses or ward nurses. It was all so new. Being in such different surroundings with a whole new team of people that were caring for Frankie was really hard. The cardiology staff from day one of Frankie's life in our usual hospital were the key part in me coping with all that had happened with his heart. The support and advice they gave me helped me be the mum Frankie needed me to be. So to not have these people around this time was really hard. However, Frankie recovered so well this time, and his determination gave me the strength to focus on his recovery and get him well again. This was the first surgery in his life that he'd came back to PICU without needing a ventilator, and that in itself was amazing. After a few minor setbacks and so much effort and strength from Frankie, he was able to come home in just under 3 weeks from the date of his transplant. Frankie received his dad's kidney the day the pandemic started. Being immunosuppressed is challenged in everyday life. However, through COVID, it was terrifying. On a day-to-day basis as Frankie's mum, I worry about illness and infection anyway. But now the entire world was locked down because of a virus. We were so scared. However, although Frankie did contract COVID twice, thankfully he was okay. I know the pandemic was challenging for everyone in different places, different problems for different people. Just felt massive to us when our son was in the extremely vulnerable category and was advised to shield for nearly 12 months. Thankfully, though, as time went on and the virus became weaker, we were finally able to show Frankie some of the things he had been missing out on for all of these years. We went on our first family holiday to Spain in May 2021, and to see him finally enjoying life was amazing. However, in July 2021, the team found some antibodies to Frankie's heart in a routine blood test. Frankie was shown no signs of rejection. He was well in himself and full of energy. We were asked to take him for an echocardiogram to see if his heart function had been affected by the antibodies. Unfortunately, even though he seemed okay, the scan showed that his heart was starting to struggle, and a biopsy confirmed that he was in fact in rejection. For 5 years, this is what we had been most scared of, and now it was happening. It came from nowhere and knocked us off our feet. There is no way you can prepare yourself for it, questioning if his time was up, wondering if this was as far as he could go. The unknown makes me anxious, but the team were incredible once again. They wiped his body of antibodies and gave him all the necessary treatments and care, and after a 4-week hospital admission, Frankie came home. He still attends Freeman every 4 weeks for IVIG treatment through his Hickman line. He will need this until his body starts to make its own antibodies again. We're not sure how long that will take, but he is still here and is still fighting, and that is down to our amazing team at the Freeman and his incredibly brave donor and their family. Frankie will always amaze me. His strength gets us all through. He really is my hero. Being Frankie's mum has without a doubt been challenging and the most difficult times of my life. To watch him suffer for 5 years with organ failure of both heart and kidneys has been heartbreaking. But Frankie has taught us so much. It has also been the most rewarding 5 years to see him fight whatever has been thrown at him and always fighting with his beautiful smile. He is so strong and determined and is forever looking to the future. He amazes me every step of the way, and I know one day he will get to wherever he wants to be. I truly believe that my coping mechanism is to know all of the information I can so I can process it and deal with it. The most important thing with a sick child is for the parents to have the knowledge so that they can feel as comfortable as they can with the situation. I think it is important that we as families help the team to understand exactly what kind of people we are and how we would like the information given to us. I've been under many teams with Frankie's health, and some work with parents much better than others. I believe as long as the parents' wishes are respected wherever they can be, things can go a lot smoother. Frankie has always been amazing, and he literally is the reason I am who I am today. His resilience to all that he's been through is incredible. He is doing so well now, but it has been a long 10 years. I am a realist, however, and I know Frankie's heart and kidney will not last forever. The hardest part of this is not knowing when organ failure will creep up on us again and not knowing which organ that will be. Obviously, transplants come with their own complications and risks, but we have been so lucky that he's received the gift of life twice. So although the future does scare me, for now we are finally enjoying showing our amazing little boy how much fun life can be now that he's well enough to enjoy it. When I think back on all of the bad news we've been given over the past 10 years, I find it hard to believe he has made it through so much when all along the chances of him surviving were never the best. He, however, is the best, and like I said at my 20-week scan, I will fight alongside him for however long he can fight. You coming back?
I don't know what Kay wants.
Thanks, Sophie. I was just giving everybody a minute. It seemed a bit inappropriate for me to jump in there. Thank you so much. As always, you just deliver such a powerful story, Sophie. And I know it's completely genuine and from the heart, and that's what makes it so powerful. Thank you for sharing your insight. Are you happy to take any questions, or would you rather not? That's absolutely up to you.
Oh, I can. It's fine. You come
Yeah.
Come on.
You're getting thank yous and lots of applauding hands. I don't know whether you can see them. We do have somebody with the hand up. Nicola, if you can get there quicker than me, I would.
Do you want them
Oh,
highlighted?
there we
Katie
go.
Simpson.
Katie. Yes, Katie. Just going to allow your mic if you're happy to come in and ask a question. You will need to unmute yourself.
Oh, sorry, I think I pressed it on accident.
Oh, no problem. No problem at all.
You can ask us questions.
Sophie, I will ask you a question if that's okay, while people are just thinking and digesting everything you've had to say there. You talked about two very different experiences, and just to explain, I think, to people that don't know, although most people do, our heart services are not on the Great North Children's Hospital, which is the children's hospital site in the northeast. We have two separate sites providing the care for children. So you talked about the experiences of two different teams. How I mean, you did say that it was hard, but how much did that really impact you? Because I guess you'd grown up with, or Frankie had grown up with, this cardiology team, and then you had to learn the ways of a whole different service. Can you say anything more about that?
Yeah, it wasn't just Frankie, I suppose, who had grown up with the cardiology team. I was only 21 when I had Frankie, and I was pretty much like on my own a lot of the time.
Yeah.
And if it wasn't for the staff, like all of the staff at Freeman, I don't think I would have been able to be the mum Frankie needed us to be. They were there a lot for me as well as they were for Frankie. And I think over at the Great North Children's Hospital, without saying too much, that it's just different. Like, I don't know. Obviously they're really good with the patients and stuff. I just don't feel like the parent or family side of it is anywhere near it like it is at the Freeman. I definitely feel like at Freeman the families are really supported as well as the patient, whereas just over there it's just not. And even Frankie himself feels a lot safer and a lot. I think they just take the time to get to know you, and yeah, I don't know. I just think all together it's just much better. Yeah.
It's interesting you say that. You could understand then, if we're looking at the other teams and the other challenges that they have, how hard it is to then receive a patient who's been in the Newcastle family for such a long time, because both think, well, this is never going to be good enough, because you have grown up with that service itself. So I can imagine for the other teams it's really challenging taking on a patient that's had a lifelong care at the Freeman.
We always used to say when we first went over that we were just spoiled at the Freeman, and that we just I think we probably are spoiled at the Freeman, to be fair, but yeah.
Just to bite in there, Kay, though, that also is in the shared care type view as well. So the patients get to know us in here and how we deal with things and how we want things dealt with. And so when they go into their local hospitals, again, we're not trying to make monsters. It's just that they're aware of how we work and what the things that we need. So that highlights that, and that's just a hospital that's a mile and a half of the way down the road.
Yeah, well, hopefully a lot of the information shared today will help with that understanding about why we all are the way we are, I guess, in the minute detail to preserving these precious lives through transplantation pathway. Is there anything else you wanted to add around sort of Sophie's story, Frankie's story, sorry, Terry?
Yeah, we all know Frankie very, very well. He's an absolute monster. We love him to bits. But he has been through all parts of the journey within transplantation. He's had the renal side, which we're a lot better at now. Renal issues are aren't so bad. The problems we have is that we, as Zdenka did in her talk very at the beginning of the day, we do a lot of congenital transplant patients like Frankie, and it's often the kidney issues pre-transplant which cause the issues post-transplant now. If you go back an era of when I was still around, unfortunately, like 10, 15 years ago, we used to run much higher immunosuppression levels, which would cause more renal conditions and more renal transplants. So the thankful thing is that renal transplants aren't that common due to tacrolimus and cyclosporin, but mostly due to congenital patients that had issues pre-transplant due to their kidneys failing at that point and the hits that they took at that point. And Frankie took a different route of rejection, which is the antibody route, which does require more intensive treatment. We talked about rejection earlier in the steroid treatment, cellular rejection, and that is a quick fix. You normally can get them back on their perch after a short period of time, and don't forget about it, but you kind of live with that. Frankie's has caused antibody rejection, which caused him to have rituximab, which turned off their B cells, which means he gets IVIG every 3 to 4 weeks, hopefully, if his Hickman line works. And so he continues that until his B cells will come back naturally. The rituximab basically switches his body off and on again, just like you do with a computer failing. You turn it on and off again. Every IT person tells you to. That's what we've done with him. And at some point, we hope for him to start creating his own B cells again, which means he doesn't need the IVIG. I do know there's a few people online that look after some of our patients that do that. And they do often email me saying, when will they not need the IVIG again? It's a bit of an open question when it's literally whenever. But we have patients that come back on after 6 months, and it can be, as mum knows, life. It just depends on the individual.
Sophie, can I ask about school and I guess the normal, all those things you really wanted for him? So Frankie goes to school?
Yeah.
Does he go to school? Yeah. And how is he with his peers? Does he ever talk about or describe any of his experiences? Or because I mean, I know he has a Hickman line, he has sort of wounds, scars, not wounds, he has scars. Does he ever talk about or share any of his experiences?
He's getting a lot better at it. He used to be really embarrassed by it, I think, but I think
he?
with age he is definitely, he's more aware of it. And I think as he's getting older and understands more why he has the scars and why he needs the Hickman line, he's willing to, like, the PA teacher just pulled us last week actually and said one of the boys had knocked him by accident. And they were like, "Oh, miss, I'm sorry, I think I've heard Frankie Lord." And Frankie was like, "It's all right, miss, can I show him where it is, just so he knows next time to try and be a bit more careful." So I think the older he's getting, the better. Like, he is willing to show a little bit more, but he did used to be really embarrassed by it.
Yeah. I must have asked that question at the same time as Samantha Collins was probably typing. I'll just make sure I've captured everything she wanted to say. How much does Frankie understand about everything he has been through? Do you find he wants to know more as he has gotten older? And can you share some positive and negative experiences with regards to communication? For example, what could nurses do to support communication in children in these situations?
I think Frankie's probably a lot like me, and as Terry and everybody else knows, I'm a bit of a pain in the bum. I like to know everything, and I like to make sure that I understand as much as I can. And I think Frankie, growing up with me doing that for him, he probably is just like that anyway. I think it totally depends on what kind of child it is or what kind of parent they have. Or, like I was saying before, I think we as families have to let the team know what kind of people we are in order for them to give us maybe the right amount of information, or not honest, because I know obviously everyone's honest, but like, I like things to be told of us whether they're really upsetting or not. I've met a lot of parents who would rather just go day by day and not know everything. So yeah, I think that just totally depends on what child you've got. But I mean, he's very aware that the heart came from somebody else, and that person obviously is no longer here. Also that one day he probably will need another heart transplant and the kidney won't last forever. But I think we're just very open with him as much as we can be. It has probably made him a little anxious, and
I was going to buy in. Frankie is totally like his mum. He does want to know. He pretends he doesn't want to know, but he does want to know. He always asks questions. He always wants to know. And he does get psychological support. He's obviously had a rough time and been through several surgeries, in and out. Each time we say to him, "You've got over that hurdle," and another hurdle appears, and I'm sure he thinks we lie to him sometimes, because we say, "That's it, you've done this time," and suddenly he's back in again. He had a Hickman line put in not so long ago, and we've had to replace that because that stopped working, and he's anxious of needles. So you've got to go through all of those processes with him. But the only way to get to the other side with Frankie, like his mother, is to tell him exactly what's coming up, exactly what's going to come in. He's coming in for a new Hickman line. We will not give him a cannula to put him to sleep. We'll use the mask. He can play with the mask before going up. He will get a pre-med, and he will ask those questions. So getting to know Frankie is how you deal with that situation. So I don't know if you've got any positive and negative nursing things. I am sat next to you.
I actually don't have any negative, and that's not just because you're sat next to me. It really isn't. Like, you've just literally hit the nail on the head. The fact that you take the time to get to know Frankie without me being as annoying as I can be. Frankie just feels safe around you because he knows that you know him. Like you do. You spend time with him, like asking normal things as well as the medical things, you know what I mean? And he just knows that he can trust you to do the best thing for him, which is exactly how I feel as his mum. So
one of the, and I'm not picking this up as a different team, but I'm thinking more on a bigger scale, is that I know you've struggled with the Great North Children's team in the sense of their frequency of communication sometimes, and access and stuff. So often families, when they're more out in the community like ours are around the country, sometimes struggle with communication in that sense, and that's what we try. Our phones are always on. Our secretaries have got ours. There's somebody else answering phone calls, so we try and make ourselves as open as possible to communication for the families, and then try and get back to them in a timely fashion. We do use emails, we use texts to the family, so if we can't directly ring them, we will message them to try and say, "Look, don't worry, we'll be back to you tomorrow because it's not actually urgent," or something of that nature, so they're aware that we've got their message and we can communicate back with them. Because I do know from experience, and other parents as well, is that sometimes it's the not knowing, i.e. I've contacted someone, they said to come back to me and they haven't yet, that type of situation.
Yeah. I hope that answers your question, Samantha. Certainly from that, I got that about knowing the whole person, not just describing and talking to them about the heart problem and what's wrong with the heart, but actually knowing what their likes and their interests and the real life outside of the hospital is all about. So yeah, really appreciate your comments there. I can't find any other comments in the Q&A at the moment.
Okay, there is one more question.
Oh,
Zdenka.
oh,
Can you hear me?
Yes, we can hear you.
There is one question from Samantha Collins.
Yeah, I've just done that one.
So then for Gillian Stokes. I think this is just now.
Yeah.
Yes, just come in.
As a shared care centre, I value your input, help and recommendations, suggestions when I am irritating you sometimes on a daily basis. So thank you all. This study day has been really helpful.
Thanks, Jill. I'll pay you later as well.
Okay, so I think we'll round up Sophie's part of the session there and say a huge thank you. And we're going to move to the panel Q&A, for which you are certainly welcome to be a part of, Sophie, if you want to relocate to the centre of the room, or you can scoot off. That's your call. So just while the team move the camera around, and Zdenka's relocated to an office by the looks of it.
No, but do you want me to come to the table?
It doesn't matter, as long as I can see you and you can get involved. If anybody has anything to ask you, that's absolutely fine.
Okay, in that case, I'll just stay in my office, yeah.
That's fine, no problem. So thank you to absolutely all of the faculty who have given the time to present today. It's been a really holistic programme, sort of taking us right through the pathway of care for this population of heart failure patients, paediatric patients, through to transplantation and onto that pathway. So what I'd like to do now is, we have had a lot of questions in the comments box, and please feel free to do them and I can read them out on your behalf. But equally, if you'd like to just raise your hand, I can unmute your microphone and you can take the floor and ask any further questions you wish to do so. So just while we're waiting for any questions to come in, I'll just open the floor back to the panel and say, are there any sort of reflections from today? Anything you'd like to sort of further build on, or any comments? It's over to you.
No, I just thank everyone that there's been lots and lots of people that have joined. So I'd like to thank everyone for joining and taking their time out. Transplant means a lot to all of us here at the Freeman, and we can't do it without your help in the community. I would appreciate if people can fill in the feedback form, because this is the first time we've set up such a day, and we chatted about it at lunchtime, where we would like to be face to face, because our talks are very dry when they're not interactive. We prefer it to be interactive. When we do education and with the families on the board, it's more of a chat than an education, and it goes along side by side. So one of the hindrances from our point of view was it wasn't interactive as much. That's just the technology and how it has to happen. But please fill in the feedback and give honest reviews of what you thought. And if there's anything else you would like, we could probably do 2-3 days on more medical things, surgical options, psychology team, physios coming in talking. This was felt to be a good starter. So if anyone wants any more views for future talks, please fill it in on the things that Kays will send around, which hopefully isn't for the QR code was before. And we can get feedback and take it from there. But yeah, thank you very much, everyone, for joining.
Thanks, Terry. Zdenka?
Yes, while we are waiting for questions, I also like to say thank you to Terry, who created the program, and he really gathered all speakers. And also to Kay, who is really fantastic facilitator. This is the first time I attended meetings run by Kay, and I think you mastered it.
Oh, thank you. I'll take that.
I was just going to say,
And third thing, we really like to see your faces. So face-to-face meeting, I am for it. Yeah.
I was just going to mention as well how much we appreciate all of the people who are involved in shared care throughout the UK with us. I mean, it makes such a huge difference when we've got other teams and we can't see our patients face to face all the time, and when they're coming from such a distance. We massively appreciate when things are shared with us. So whether that be it, how patients looked in clinic, to echoes, ECGs, to bloods, and when it's done in such a timely fashion, which it often is. So we massively appreciate it. We probably don't say thank you enough, but thank you to everybody who does do that and does it so well.
Yeah, just to add on to that, because Jill said about her phone calls being annoying. They're never annoying because you're helping us to look after the patients that we look after. We have massive issues with getting hold of lab results because some centres have now gone to email only, and we have no control of when those emails will be replied to. Some we have to wait for the results to go back to the GP before we get. So any help that the liaison nurses, community nurses, all you people that help us out is greatly received, because we will go mad otherwise without your assistance. So yeah, thank you.
Just in answer to the question about slides and I guess the content from today's programme, what we will do, and Nicola, I'm hoping you're going to say yes, is that we'll convert them into PDF and we'll share them on our education platform, which is where the YouTube video from today is going to go.
Yeah, that's
and
no
be
problem.
hosted. Yeah, so we'll pop the slides on there as well, and that's just at the North East and North Cumbria CHD network website page, and we'll share the details with you in the email. Any other questions? Because I don't want to keep anybody longer than we need to today, but I equally don't want to miss anybody. There's lots of thank yous for the faculty in the comments box, so you might want to have a look at them. And I can't see any more questions, so I'm going to close today by just saying thank you to all of our specialist team for taking the time to share your high-level expertise and knowledge. It's been very much appreciated, and I'm sure we'll see that in the feedback that we collate, and I'll share that with you as soon as we have it. So without further ado, I'll just say thank you and enjoy the rest of your day, everybody.
Thank
Take
you.
care. Bye-bye.
Bye. Thank you.
Don't leave.
Nicola, can you end the recording? I don't appear to have an option.
Yeah, I think it stopped
stopped
after
at
4
the end,
hours and
didn't
then restarted.
That's fine.
So, yeah, stop. It just says start.
Yeah, it's fine. I think it's when we close down the call.
You can always just ring through back to me if you want in the chat after.
Yeah, okay. Well, I'll exit. Thanks, everybody.
Thank you.